Assalamu alaikum, everyone. My name is Samir Odeh. I'm a second year medical student. And today, inshallah, we'll be talking about the integrated cardiac control and some clinical applications of the cardiac integration system of the human body. So let's get started. First, I'd like to discuss orthostatic hypertension and some extension of the baroreceptor reflex. Then, inshallah, we'll be discussing the role of exercise and cardiac conditioning on the heart. Then we'll be looking at the Valsalva maneuver, the different stages of it. Then we'll talk about some applications of shock, what exactly is shock, some different types of shock. And then finally, we'll end this, inshallah, with a discussion on heart failure. And within each essentially section or part, we're going to have some nice clinical applications and some practice questions. So let's get started. These are the learning objectives for this session. This really isn't necessary, but if you just want to know exactly what we're going to be talking about, these are the same ones on Dr. Simon's slides. This is including both P13 and P14. So it's both those slides in just one nice condensed PAL. Okay, so let's just discuss some of the approach, or my approach at least, when it came to essentially not solving this lecture, to digesting this lecture and kind of understanding this lecture. Essentially, what you need to do is have an open mind and always look at the questions from a pretty wide perspective. Rely on certain axioms and facts that you know that you specifically learned from your previous lecture. So for example, I hope that everyone here today has made sure to study the 11th and 12th physiological lecture about the integrated cardiac control system, so about the nucleus tractus solitarius. I'm still going to be recapping that today, inshallah, so don't worry at all if you didn't really focus on that lecture too much. But essentially, what's so important for this lecture, and what's so important to actually be able to target and solve the questions from this lecture specifically, is that you need to have a good understanding of the process and kind of imagine it in your mind. So essentially, when you see that question, you can be like, okay, I can see that this is going to cause vasodilation. That's going to cause a decrease in mean arterial pressure. That's going to be detected by what the baroreceptors here and here. They're going to send a afferent signal to the NTS. The NTS is going to do this. So you kind of need to think that way. Think methodically, rely on certain facts, and then inshallah, you're going to be getting the questions. So first thing, we're going to talk about the baroreceptor reflex and how that relates to orthostatic hypertension. So essentially, what is orthostasis? Essentially, when we're laying down, we're like this. Imagine us as a tube of blood. So blood is equally distributed all across the body, as in the pressure is very similar. You have the pressure of blood here, arterially, is the same as the pressure here, which is the same as the pressure here. So there really is a very, very small difference in between the blood pressures all across the body. With the venous pressure, it's kind of the exact same thing. Very similar pressures across the body. It honestly doesn't even make sense. It doesn't make a difference, sorry, when you're comparing the different pressures across the body when we're horizontally, when we're supine. Supine, by the way, means we're laying down. We're standing means we're standing, okay? So the thing is, as human beings who live on Earth, we are unfortunately acted on by the force of gravity. So that means when we go from laying down, supine, to standing up, all the blood obviously will be dragged towards the ground. So essentially, even though the pressures were equally distributed when we were supine, when we stand up, all the blood is going to cool down because remember, humans are just a tube of blood, but we're actually an advanced tube of blood. So that means when you're standing, your lower extremities, they're going to have far higher pressure than your upper extremities, especially when you raise your hand like this person here. This means that the blood is just going to go straight down. And the veins in your hand are going to be extremely low pressure. So low pressure that the veins collapse. Why? Because all the blood is being sucked out, it's being sucked towards the ground, towards your feet. Now, your lower extremities, on the other hand, they're grabbing all that blood. These are capacitance vessels, and I'm assuming you know what that means from your hemodynamics lecture. Veins are very compliant, which means as soon as just blood comes in, they'll dilate and they'll accept that blood right off. So they're great capacitance vessels, again, for holding that blood, but this is not something we want when we're just standing up suddenly. So if we were just, again, like I said, a tube filled with water or blood, we would die if we changed positions like that because gravity would just pull us like that, pull the blood down, sorry. However, thankfully, we do have a mechanism in place to prevent all that blood from going here to going down to your legs. Because again, your brain does need blood, needs to be perfused. If the brain isn't perfused, does anyone know what happens when your brain isn't perfused? Okay. Essentially, what happens is syncope. You faint. And we're going to discuss that soon, inshallah. So, but one thing you do need to remember and keep in mind for your exam, however, is that the arterial blood pressure, not the venous blood pressure, the arterial blood pressure, it changes by about 0.78 millimeters of mercury every centimeter away from the heart. And this is subtracted or it is added to your mean arterial pressure. Now, I think all of you know how to calculate mean arterial pressure. It is essentially your diastolic plus your pulse pressure, sorry. Um, so if your mean arterial pressure was 100 and you're around 78 centimeters below, sorry, 78 centimeters above your heart, your blood pressure would be 100 minus 61. Again, pressure up in your brain when standing would be lower than the pressure in your legs. Again, we just discussed why. So I know that was a lot to take in, but let's kind of just imagine it. So I think all of you know what edema is. Edema, essentially, it is the pathological pooling of blood in the interstitial space. Essentially, it is just expansion of anything with water. So because we have blood pooling into our large capacitance vessels in our lower extremities, because again, they're very compliant and gravity just pulls it down, you're far more likely to have edema. And essentially, um, blood is just pooling into the lowest place you can find, and those vessels are accepting it right up. The thing is, this is an issue for humans, again, without any compensatory mechanisms, because veins can't contract, or at least not as like arteries. Arteries are, again, very vascular. Epinephrine comes in, you'll get vasoconstriction. It's very effective. However, even with a baroreceptor mechanism, bear with me, we'll discuss it soon. The blood, if it pulled in your veins, especially in your lower extremities, nothing can happen. Essentially, it's just going to stay there. And we'll see what happens if you keep standing and that baroreceptor reflex does nothing. So this is just a preamble, essentially, to have you start thinking that we need a mechanism to force this blood out of our legs and back into the circulatory system, or we're going to faint, as in we're going to lose pressure. All right. So going back to your previous lecture, we're going to start talking about the nucleus tractus solitarius, also known as the solitary tract nucleus in English versus Latin. Essentially, it's a part of the brain that is an integration center. I know you're probably taking pulmonary physiology right now, and you probably just discussed the respiratory center. This is very similar to that. We even receive signal from the respiratory center. So what it is, it's just one part of the brain that accepts signals from all over the body. So it accepts signals from your baroreceptors, which are in your carotid arch and your heart. It accepts signals from your blood. It accepts signals from your osmoreceptors. It accepts all this data. And what it does with its data, it determines what the next step is going to be. So, like I said, it receives signals from a lot of different locations. And the one location we're going to be focused on, inshallah, today is the baroreceptors. The baroreceptors, there's mainly two that you should focus on. It comes from your carotid arch and also from your heart. The one from your carotid is via your glossopharyngeal nerve, and the one from your heart, it's from your vagus. Again, these are afferent nerves, not efferent. So afferent means they go back into the central nervous system. Okay, so baroreceptors, they are tonically active, which means that the signal, it's always a positive signal. Now, what does a positive signal versus a negative signal mean? Essentially, positive signals are signals that are excitatory. That means the neurotransmitting chemical is glutamate. A negative signal means the signal inhibits whatever comes after it. That means the neurotransmitter, in this case, is GABA. Now, if we just said that these receptors that sense pressure in these two locations are tonically active, so they're always sending a signal, they're going to go into a center. They're going to go to a center called the nucleus tractus solitarius. That is just what I explained right now. This center, essentially think of it as having a fork in the road. One hand of the fork, you see this is the NTS. One hand of the fork is going to go into a neuron called the caudal ventrolateral medulla. The caudal ventrolateral medulla, it takes that positive signal. So that positive signal, in this case, again, is glutamate. It takes that positive signal and it attaches it to another neuron. It's called an interneuron because it's in between two neurons. And what it does is it changes that signal to a negative signal. That negative signal releases what? Releases GABA. So you see how this was glutamate here, but it's GABA here? Because the GABA is going to act on neurons in the vasomotor center. The vasomotor center, what it is responsible for, it is responsible for your sympathetic drive, essentially for your sympathetic system. Now, the vasomotor center, it has a neuron in it, and that neuron is excitatory. So again, just to recap, we had excitatory from the vagus and glossopharyngeal, then another excitatory neuron from the nucleus tractus solitarius to the caudal ventrolateral medulla, and then the CVM changed it into a negative signal. Now that negative signal acts upon a tonically active center called the vasomotor center. What tonically active means, it just means that it's always on. This means that if you had an increase in pressure, the sum of all those positive, negative signs would again be overall positive, and in the end, it would be changed negative. That means we have an inhibition of the sympathetic drive coming out from this vasomotor center and through the bulbospinal tract. The bulbospinal tract, if you just follow this arrow right here, it goes into your sympathetic ganglia. What does sympathetic ganglia do? It releases epinephrine. Epinephrine has its various effects. Norepinephrine, sorry, and then it releases norepinephrine to the adrenal medulla, which then releases epinephrine. So that was one fork of the road. Like we said, there are two forks. The second fork of this road is the excitatory neuron, so glutamatergic, going to your dorsal motor nucleus. Yes, your dorsal motor nucleus and your nucleus ambiguous in your cardioinhibitory center. So essentially, there are two nuclei, and what are they responsible for? Your parasympathetic drive. So parasympathetic drive just means that the signals coming out of your 10th cranial nerve, so the vagus nerve, and you all know what the parasympathetic system is responsible for. So slowing down your heart, vasodilating your vessels through nitric oxide synthase, and so on and so forth. So that was quite dense, but let's just think it through very quickly. So let's say you had a decreased signal being sensed by your baroreceptors. You just went from supine to standing very quick. That decreased signal means you have decreased glutamate being released into your nucleus tractus solitarius. That decreased concentration of glutamate being released essentially means less glutamate is activating your cardioinhibitory center, which means less parasympathetic drive. And it also means less glutamate is going to your CVM, so your caudal ventrolateral medulla. When you have less positive signal into a negative neuron like the CVM, essentially means whatever after it is becoming more stimulated because it's becoming less inhibited. So the total sum of all this neurotransmission is increased bulbospinal tract activity. That again goes into your it goes into the parasympathetic system, the sympathetic system, sorry, and that has its various effects. So let's take what we learned and draw a very simple mind map of what happens when you have decreased blood pressure that is being sensed by your baroreceptors. So I'd like everyone to grab your nearest piece of paper or just kind of bear with me as we draw what happens. And trust me, when you draw it out yourself, it is incredibly helpful. You'll just understand everything. So our first thing that we have is we're going from a supine position to a standing position. As we know, the blood pressure is going to decrease. Now, because the blood pressure has decreased, our baroreceptors, which they're here and here. Let's say that's the heart and that's the carotid, what's it called, the carotid vessels. They're going to detect that signal through our two nerves, so the vagus and the glossopharyngeal. They're going to detect it, and they're going to take it all the way to the nucleus tractus solitarius. So this is just a very rudimentary brain. Okay, and that is the nucleus tractus solitarius. Now, you need to know that these two afferent nerves, again, what do they secrete? They secrete glutamate. And we're going to make all the neurons that secrete glutamate green, okay? If they secrete glutamate, what are they? They're excitatory. And if they secrete GABA, what are they? They're inhibitory. So knowing that, let's draw everything out. And trust me, it becomes so much easier. So Glutamate is released, and glutamate acts on the nucleus tractus solitarius. As we know, the nucleus tractus solitarius has two paths that it can take. One, firstly, is to our cardio-inhibitory center. This cardio-inhibitory center is just our dorsal motor nucleus and our nucleus ambiguus. These are just two cells that are responsible for secreting acetylcholine, as in your parasympathetic nervous system. For now, that's all you need to know, and that's just going to help you. So let's have our parasympathetic nervous system be this bright purple. So kind of differentiate it from GABA if you can. Okay, this is very simple. It goes just from the nucleus tractus solitarius to the cardioinhibitory center, and the signal that comes out of that center is just acetylcholine. It's the parasympathetic nervous system neurotransmitter. Okay, and what does this do? This one acts on your heart via muscarinic 2 receptors. It just acts on your heart and it decreases it. And then the second way, this is your heart, and your heart's going down. It's sad because the heart rate's going down. Then the second mechanism, which the parasympathetic nervous system has on the heart at least, is through the blood vessels, and it's going to cause vasodilation. And how's it going to cause vasodilation? Because it's a muscarinic receptor linked to nitric oxide synthase. And I think, as you know from your previous lecture, by the metabolic theory, nitric oxide synthase is one of those chemicals that can cause a vasodilation. So that is for our first center. The second tract we have, as you can see, is our caudal ventrolateral medulla. Now, our caudal ventrolateral medulla, essentially what it does, it takes that positive signal and it turns it into a negative signal. That means that signal is now releasing GABA, which is depressing whatever cell comes in front of it. So the unfortunate part is that this signal is going what? It's going into your vasomotor center. Now your vasomotor center, it's responsible essentially for stimulating your sympathetic nervous system. And whatever you depress, it's going to depress your sympathetic nervous system. So let's have our sympathetic nervous system be pink, for example. Your sympathetic nervous system. I don't know. Yes. So essentially, the signal that comes, again, I'm saying it a lot of times and repeating it just so we can be very clear. The signal that comes through your nucleus tractus solitarius, it's coming out as excitatory glutamate-based signal. It's reaching the interneuron called your caudal ventrolateral medulla and changing into a negative signal, as in GABA is being released. That is acting on the center in front of it. So you have this neurotransmitter, you have your terminal bouton, it's releasing that negative signal, and it's inhibiting the center in front of it, which is the vasomotor center. The vasomotor center, it is just your sympathetic nervous system's primary neuron. So this will then act on your alpha receptors, which will cause vasoconstriction, and will act on your beta receptors, which will again stimulate your heart. So basically, why are we doing this? It's just looking at the signal. If you have a decrease in blood pressure here that is being sent, that means less glutamate is being released. That means less stimulation of your cardioinhibitory center. This also means less glutamate being released into that caudal ventrolateral medulla and less negative signal is being released. By having this less negative signal here, this means you have less inhibition of your vasomotor center. And the sum of that less inhibition, means that this sympathetic drive is now increasing. And the whole point of this sympathetic drive is simply to regulate what is happening here. And it's causing a rise in your blood pressure to prevent that, to stop that negative signal that is receiving. So if I did this right, in theory, it should look like the drawing after it, and is very similar. Essentially, you can compare it if you want. You can just try drawing on your own. It helps you because once you kind of are able to draw it out, you're able to memorize it, and it's all very clear. However, one thing I forgot, which I wrote here, is that the thing is, no matter how low your blood pressure goes, and no matter how much sympathetic stimulation your nucleus tractus solitarius is causing, so your beta 1 and your alpha stimulation, which are trying to regulate your blood pressure back to where it was, no matter how much you do, if you don't move your legs, if that blood keeps pooling in your large capacitance vessels, you're gonna faint. Because thing is, we can't, no matter what you do, you can't stimulate veins to pump that blood out. That blood has to be moved by other ways. So, why do people have something called orthostatic hypotension? Orthostatic hypotension. Essentially, this means movement, stasis, low blood pressure. We just translate all those words. It means that upon standing up from a supine position, your blood pressure falls. And that shouldn't happen. Your blood pressure should slightly fall, which cause a reflex increase in your baroreceptor reflex, and it cause, again, a reflex increase in sympathetic drive. So this could be due to a variety of reasons, which could be one, a dysfunctional baroreceptor reflex. So there could be a nervous injury. It could be due to drugs. Certain drugs can depress this reflex. So these are your alpha agonists. Again, this is just something I'm going to take inshallah in the future, so don't worry about it. Or it could be hypovolemia. Because think about it, if you just don't have enough blood going around, your pressure is going to be low. No matter how much your heart stimulates itself, it's not going to make up for it. So a great way of determining if someone has orthostatic hypotension is using something called a tilt table. Essentially what this is, it's a test where a patient is strapped into a bed and just does this. So what that does is, again, just like how we described, if you imagine someone as a tube of blood, all that blood's going to go to their legs. And should they actually have an issue with their baroreceptor reflex, their blood pressure is going to fall, they're going to faint. Now, as you can see here, this is the results of a tilt table test. Now, in a normal person, you should see this. You should see an increase in blood pressure. However, in someone with a dysfunctional baroreceptor reflex, you will see essentially a crash in blood pressure. And this means that there's an issue wrong with their baroreceptor reflex and they're prone to fainting. Now, let's think of what happens if you stand for a very long time. So imagine you're standing on the sun, you're queuing up for something. Maybe it's like this new, very famous coffee shop that everyone's going to, and you did a horrible decision by actually queuing up. Now, what happens is, again, like we said, that baroreceptor reflex has a main caveat, which it only works up to a certain point. If all that blood is still pooling into your legs, into those very welcoming capacitance vessels, eventually going to run out of blood in your actual actual circulatory system. And this is just a very simple diagram which kind of depicts that standing gravity. Gravity pulls all your blood into these very accepting capacitance vessels. So think of it as a vault. The thing is, if you remember your hemodynamics lecture, this will cause increased hydrostatic pressure within the capillaries, and that increased hydrostatic pressure is going to cause filtration. So net filtration of plasma out of the capillaries and out of the vessels. Now less blood is returning because even though you do have blood pooling, you have some blood going back. Now there's very little blood going back. And essentially within 5 minutes of standing motionless, you're going to run out of blood. Your mean arterial pressure is going to come crashing down. Your brain's going to lose perfusion, and you're finally going to faint. So it's very important to think of everything in a sequential order. And once you nail down that main integration center diagram in your head, inshallah, you're going to very easily figure out what happens after specific steps. So with that in mind, I kept referencing how the baroreceptor reflex, it's great, but it only works up to a certain point. Now, what are the instances where we have systems that can ensure that we don't run out of plasma when we're standing? And there's 3 main ways, if you can call the third one a way. The first is the thoracic pump. Essentially, the thoracic pump, it's a very fancy way of just saying your thorax expands, and that does a bunch of stuff which allows the blood to go back into your heart. So remember, the heart is attached to the thorax. Everything is really attached. So when you take a deep inspiration, your abdominal wall, or sorry, your thoracic cage expands. This is going to cause the pressure within the thoracic cavity to decrease. When the pressure in the thoracic cavity decreases, the heart's atrial pressure also decreases because again it's attached to that thoracic wall. So this will cause the right atrial pressure to decrease. And as you know, the right atrium is where is what accepts the blood from your inferior vena cava and your superior vena cava. So if we decrease that pressure gradient between the farthest point in your body and the right atrium, that is going to cause a increase in the venous return. And when we increase venous return, we're increasing stroke volume, which increases cardiac output, because again, it's heart rate times stroke volume. That increased cardiac output maintains our mean arterial pressure. So that's one way that we can ensure that we are maintaining blood pressure when we're standing. Now, the second mechanism is the leg pump. It's called a lot of things. It's called the muscle pump, the leg pump. You can find a bunch of different terminologies for it. However, essentially, remember how I told you the veins in our legs are very welcoming. They're capacitance vessels, like your inferior vena cava. Those veins, they run right in the middle of muscles. So inshallah, you're going to take this in your musculoskeletal block, the leg muscles, but you'll see that the main veins that run right through, so whether it's your femoral, whether it's your tibial, whether it's your whatever, these veins run right through the middle of these muscles. So even though these veins are dilated and filled to the brim with blood that is coming down because you're standing for such a long time, the moment you just contract your muscles, so moving your leg, adjusting your feet, adjusting your stance, doing anything, walking, running, those muscles are going to contract and it's going to shove the blood right back up. And combined with your thoracic pump and a decrease in pressure in your thorax, that is very effectively going to shove all that blood back into the heart where it should belong and increase your venous return and counteract the effects of any hypotensive crises caused by standing for too long. And another mechanism that kind of helps this is that the veins in our body, they have valves, and essentially these valves are in the direction of the blood flow. So even though the blood squirts out like this, the veins will shut back, which means that if the blood comes back for any number of reasons, it can't, go back to where it was. It's forced to essentially just move in one direction. Now, you'll see that this mechanism kind of fails a lot of times. That's why people get things like varicose veins. But for the most part, it's very effective. And a large or a very important reason why people get deep vein thromboses, so essentially it's blood clotting in your legs in the veins of your legs, it's because that blood has pooled for so long and essentially it's become stale. It's something called decreased washout, and you're going to learn about it very soon, inshallah. It's because the blood is not moving, it's just staying in one place, it's going to predispose it to form a blood clot. And thirdly, our main, or not the main really, but it's a one mechanism if you'd consider mechanism. It's if you stand for too long, you don't move, you don't do anything, eventually your blood pressure is going to decrease. Your baroreceptor can't deal with all this excessive fluid loss of the circulatory system. Your brain is going to lose perfusion and you're just going to come crashing down. And subhanAllah, this is actually very effective in restoring your blood pressure. So, be thankful that you fainted sometimes. And this is the very nice mind map that Dr. Simon included in his lectures. It's very similar to the one I just showed you, but it's a merger between the nucleus tractus solitarius mind map that we all learned to draw and the one included in the slide before this, I think. Essentially, like we said, decreased venous return because our blood is just pooling in a very accepting place is going to cause a decrease in mean arterial pressure. The baroreceptor is going to sense that, and you know what happens after that. So yeah, and I even gave you a little important thing. Standing is going to decrease the positive signal that the baroreceptors give. And this positive signal, as we know in the vasomotor center, it's an inhibitory signal. Just one neuron becomes inhibitory, the whole thing becomes tonically inhibitory. And as we know, that inhibits a tonically active excitatory neuron, which is responsible for releasing epinephrine. So yes. All right. I hope that wasn't too much. I know I spoke so much and it honestly felt like word salad, but trust me, just try doing it a couple times, draw it, and it'll be very nice. So let's look at a clinical case. A 20-year-old man went to Buckingham Palace on his tourist trip to London. While he was there, he turned around and heard a loud thud and realized that one of the King's Guard standing outside the doors had collapsed. Now, what cardiovascular changes caused this occurrence in this collapsed guard? Can anyone tell me what they think is the answer and why? Does anyone have any answers? Can see some people in the chat. Okay. Someone has answered an answer. Does anyone want to respond and explain what they think that answer is? Can you please go quickly over the drawings? Yeah, I'll just go back to the drawings after these two questions, and it's going to help us understand the topic in depth. Okay, so for the person who answered E, you are right. Essentially, what happened is that even though his baroreceptors detected this decrease in pressure, because remember, like we said, all that blood has pulled down to his lower extremity, it's negligibly increasing the stroke volume. Because again, like I said, that system, it only works to an extent. And again, the sympathetic nervous system, the muscle distribution around the vessels, it's just primarily in the arterioles. That distribution of the muscle layer is primarily around the arterioles, and it's essentially negligible in your veins. Now, my question for you is, can we all mute? My question for you is, what could have prevented this? Out of all the mechanisms we talked about, what is one mechanism that could have prevented his collapse or his fainting? Can someone answer? Yes. So for those who answered in the chat, yes, if he just simply moved either his legs or he just moved his body, that blood would have been forced out of his capacitance vessels and back into the circulatory system. Okay, now we have another question. When a person moves from a supine position to a standing position, which of the following compensatory changes occurs? I'm going to give you guys around 30 seconds just to answer this. Guys, I'm only seeing two people answer these questions. Come on. If you have any questions, just don't hesitate to unmute and ask, or just send in the chat, and inshallah we'll go over the part that you have an issue with. Okay, so for your colleagues who said B, they are indeed correct. And this is again due to the decreased signal being detected by your baroreceptors. I'm going to go back to that drawing that we did. For the person who said, can we go back to the drawing? Do you mean this one or the one I drew? Okay, yeah, we'll go back to that one. Okay, so going back to what we said, that decreased signal being detected by your baroreceptors, because again, you're losing blood pressure for one way or another. It could be due to standing, could be due to bleeding out, could be due to a bunch of factors, due to anaphylaxis. Don't worry about that. We'll get to that later. That decreased pressure is being detected by your two receptors, which is going through your afferent nerves. Essentially, afferent means towards. So towards your central nervous system, that is being sent to your nucleus tractus solitarius, or your solitary tract nucleus. That is forking the signal, so it does this to it. And one arm is going to your cardioinhibitory center. Now, because all these neurons, they're glutamatergic, means they release glutamate, so they're excitatory. We have a decrease in excitatory signal, which means a decrease in whatever this is. And this is the parasympathetic nervous system. So that is being decreased. Now, is that a good thing or is that a bad thing in this case? Can someone tell me? Would you want to decrease the parasympathetic signal coming out of your brain if you are detecting a decreased pressure? Yes, exactly. It's a good thing. You do want to decrease the parasympathetic drive that is coming out of that center. Because again, you don't want blood to keep pooling, you don't want the pressure to get lower, you don't want your heart to become less contractile. You want to move things. Now, on the other hand, we have our vasomotor center. Or actually, before we have our vasomotor center, we have our caudal ventrolateral medulla. The caudal ventrolateral medulla changes signal from a glutamatergic to a GABAergic signal. That means this was excitatory, this is inhibitory. Now, this is less excitation in this case, because it's going to a neuron that is inhibiting, means less inhibition. Now, that less inhibition is inhibiting a tonically active center, which is called the vasomotor center. So, vasomotor, it's always on. Just think of it like that, always on vasomotor. Now, that decreased signal here means that always on, which was under the control of a negative signal, is going to become even more stimulated. And when that is more stimulated, it goes through another neuron, which is called the bulbospinal tract. So down your spine, your spinal cord, and into your intermediolateral nucleus, which has your preganglionic neurons, which goes to your sympathetic chain, and that does everything we talked about. It increases your cardiac contractility, and it constricts the arterioles, and that increases your blood pressure, which, if it was functioning correctly, it should raise your mean arterial pressure and stop that signal that is being detected by your baroreceptors. Okay. Was that good for the person who wanted just a quick review? All right, perfect. Without compensation, does standing up increase or decrease total peripheral resistance? Okay, great question. So when you stand up, nothing really changes in your vasculature. All that changes when you're standing up essentially is the blood goes from one place to another. Now that causes a reflex arc, which is the baroreceptor reflex. It's a reflex, okay? That reflex, what it does is in a functioning person with a functioning nervous system, that should raise total peripheral resistance. I'm even going to write that here. TPR should go up in a functioning baroreceptor reflex. TPR, stroke volume, stroke volume, that's kind of it's like subjective, because would stroke volume really increase if the blood was decreased in total? So don't really consider stroke volume, but heart rate 100% will increase. Heart rate and total peripheral resistance should increase when you're standing. If it doesn't, either you're taking a drug, which is inhibiting this, or you have orthostatic hypotension, which could be another issue. Does anyone have any questions regarding the first part of our session before we go on to exercise? So just quickly ask the question if you have it, otherwise we'll just move on. All right. So our next part is regarding exercise and conditioning. So essentially what exercise is, it's repeated regulated movements. And when we exercise, the cardiovascular system needs to regulate itself in order to maintain the blood flow to the muscles that are working. Because if those muscles are working so hard and they're not receiving enough blood, or the blood that is coming out of those muscles is not being pushed out fast enough, they're going to hurt themselves, whether it's through acidosis, whether through a million different things. So how do we get that increased blood to those muscles? Two main ways. Either increasing that blood flow, oops, this is not the cursor. Either increasing that blood flow or extracting more blood. Now, this increased blood flow, it's by sympathetic stimulation. So again, remember that vasomotor center. That vasomotor center, it's not that the baroreceptors are detecting a decrease in pressure. That could be it. However, it's more the fact that the nucleus tractus solitarius, remember how I said it's like a integration center? For example, think of it just like as a power grid. So all those lines just converge at one point. One of the things that stimulates the NTS is higher center control. Essentially, this is you being like, oh, I need to run, I need to fight. So this is your fight or flight reflex. And that, again, we know is a sympathetic system. And that's just going to cause increased sympathetic drive. That's just it. That's all you need to know at this point. And the second theory is the second method, sorry, is via the metabolic theory. The metabolic theory, the main way this does, increase the blood flow is through the production of metabolites such as adenosine, such as hydrogen, such as lactate. So as soon as your your blood vessel detects these metabolites, it's going to expand and it's going to cause increased blood flow. And in addition to this, um, I'm sure you're all taking pulmonary physiology right now. Again, you probably heard about the Bohr effect. This is the Bohr effect. Essentially, in more acidic environments and in lower oxygen tension environments, that hemoglobin, it's going to more readily release that oxygen. And this is going to be very beneficial for those muscles that are actively working. So one easy way to think about it is what starts everything off. What is the starting point in that baroreceptor reflex drawing that we did? It's decreased blood pressure. How is it decreased blood pressure? It's because all those blood vessels that supply the muscles, they're vasodilating. This vasodilation is causing a decrease in blood pressure. And it's because those muscles are actively consuming blood. They need so much blood that they're causing a decrease in blood pressure. And of course, what that does is it's going to be detected by your baroreceptor reflex, and it's going to cause an increase in sympathetic drive. Now, what are the changes that happen during exercise? It's really three main important changes, and these are all related to the sympathetic nervous system, innervation of the heart. So the cardiac cycle is going to shorten. This is due to chronotropic activity. Now, what is chronotropic activity? It just means time change. Now, as you know from your previous lectures, sympathetic stimulation, it does a lot of things. One of those things is it changes the electrical conduction within the heart. And one of those ways is through upregulating the expression of certain channels. So more calcium is flowing in. The constant like depolarization of the heart is essentially going faster because you have more calcium going in, and this is going to increase the heart rate. So increasing the rate of those action potentials, that is called chronotropic. Now, in addition to this, we have a decrease in the systolic phase of the cardiac cycle. Now, what that means is, yes, you are beating your heart more times per minute, so your heart rate is increasing. But what importantly is happening at the same time is that through increased sympathetic stimulation, you're activating cyclic AMP, so increased cyclic AMP, which increases protein kinase A. What protein kinase A does is it phosphorylates a protein called phospholamban. What phospholamban does is just promotes the activity of the sarcoplasmic reticulum. This is just a fancy way of saying that the calcium that is released by the sarcoplasmic reticulum upon action potential is being released so much faster and it's being sucked back in so much faster. This means that you can get that same contractility in a faster period of time. So again, in the words of Dr. Simon, you are shoving more systole in each heartbeat. So your heart is just contracting more and more and more and more and more in the period of time it has. So it's essentially almost like creating time. And of course, diastole, and the same way, is also decreased. So less pumping time also means less relaxation time, because remember, everything's just going so much faster. This means the heart is not wasting time just waiting for the ventricle to fill. Of course, in addition to the cardiac cycle's timing changes, you do have your changes in contraction. This is called your inotropic activity. Essentially, inotropism means that more calcium is being released. More calcium being released, more cross-linking between the myosin and actin is occurring, and the contractility is getting stronger. And finally, this causes an increase in ventricular and aortic pressure. And all that actually serves to increase venous return. So that increases preload. So it's essentially like a self-stimulating positive feedback loop. Now, while this is great for the vast, ranges of heart rates, essentially you do meet like a plateau because your heart is pumping blood so fast that it doesn't have enough time to fill. So you do reach this plateau, but you are very rarely reaching this plateau unless you're into extreme sports or extreme physical activity. Now, this is just a explanation of everything I just said. So chronotropism, the rate of action potentials are increased, and the heart is contracting faster in a given time. Then lusotropism is, again, phospholamban, that calcium is being uptaken faster and released faster. And finally, inotropism. Inotropism just means our frequency of heartbeats is faster. Sorry, that is the strength of the contractions are stronger. Finally, dromotropism. Now, dromotropism is important because you know how sympathetic stimulation increases those calcium channels in the sinoatrial node? Well, it does the same thing in the atrioventricular node. And the interval, the delay between the sinoatrial node, so between the atria contracting and your ventricles contracting, essentially what happens is there is less delay between that happening, and everything just moves faster. I have a question. So the plateau is when the heart contracts too fast to the point where it doesn't have time to flow. Yes, exactly. It's the heart is being so fast, it's essentially being so efficient that it's becoming inefficient. And the time that it could have used filling is now being used pumping. And that eventually, it's not negative, but it's just counterproductive. So your heart usually doesn't go that high, your heart rate. Okay. So all this essentially repeated bouts of high intensity exercise and continuous stimulation of your heart essentially is going to cause something called conditioning. And conditioning is when your heart changes or becomes more efficient to the work that it is doing. So this is just taken from Dr. Simon's slide, but what it does is that you're seeing the effects of severe conditioning. And I use severe in a very like subjective manner, not severe than it's bad, but severe in that it is very, very strong conditioning that is occurring here. So look, the heart rate essentially is halving. The maximum heart rate is increasing. Now this is it's a negligible increase, so we kind of just disregard that. The stroke volume is increasing. So the resting stroke volume means just how much blood is being shoved out of that ventricle. The exercising stroke volume is massively increased. So again, the cardiac output is the same. And the maximum cardiac output is also massively increased, again, due to that stroke volume. And the heart is just in general heavier. Now, all of this is because it's very abstract trying to explain this, but the more your heart is forced to do these jobs, this type of work, the more growth factors are released and the more adept the heart becomes. So it's more like efficient. It's like, okay, I'm gonna do this, this, this. I'm gonna increase the amount of blood I push out, increase, just becomes better. And I explain it here. So lower heart rate is lower because the heart is more efficient. So it's larger, it's stronger. Those myosin actin cross bridges are very strong. Its size, this is eccentric physiologic hypertrophy. Essentially, what all those big words mean is that the heart can hold more blood. Um, can hold more blood, essentially. It's not like the other type of hypertrophy, which is concentric pathological hypertrophy. That is in it's in hypertension, and it's actually counterproductive because even though the heart is increasing in mass, it's holding less blood. And holding less blood is actually counterproductive if you have hypertension, because again, you need more pressure to overcome the effects of a very, very non-compliant aorta. Again, but that's not the objective of this lecture. And of course, increased angiogenesis. This is just due to increased release of angiogenic growth factors, which essentially mean that even though the heart is bigger, it's not big that it's starving when it's working too hard. No, there are new capillaries that can feed the blood even in times of great stress. Okay, now all this is just so we can learn how to draw a mind map for exercise. So, can anyone tell me? I have a question before we go. Hold on. What does angiogenesis mean? Okay, so angiogenesis, essentially, it's composed of two main words. Angio, and this just means blood vessel. And then genesis, this is new. So essentially angiogenesis, it's the release of something called VEGF, and this stands for vascular endothelial growth factor. This is released when a cell is not receiving enough oxygen. And what this does is it promotes new blood vessels. The mechanism behind this, you don't need to know it right now, but essentially just know that increased exercise makes new blood vessels grow in the heart. All right, so let's draw a quick mind map of exercise. So as we said, this is a bicep. Please do not judge the drawing. As we said, increased exercise, what it's going to do is going to do two things. It's going to increase the stimulation of the sympathetic nervous system due to higher center control. Essentially, what higher center control means is that the top of your head or the top of your brain, it's your consciousness, like the consciousness part of your brain, that part and your subconscious as well, it's telling the lower part, which is the nucleus tractus solitarius, that we need more sympathetic nervous drive. Even though it might not be any changes occurring, even though there just might not be any changes to your blood pressure, your brain is telling itself it wants more sympathetic nervous system. And this happens, let's say you're just walking and you see a bear in front of you. Your blood pressure is fine, nothing happened to you, but your brain sees that threat. It sees that like flight-inducing stimuli, and it's going to be like, oh no, we need to run, and it's going to release sympathetic drive. So, like we said, there's a sympathetic nervous system aspect to it, and there's also the metabolic theory aspect of it. This is just a fancy way of saying vasodilation, because exercising muscles, they release a bunch of metabolites. I'm just going to draw them here. So things such as ADP, protons, and lactate. So what this does, it just causes the blood vessel to dilate, to wash out those potentially harmful metabolites and also bring new ones in. Now, what this does, this is that these changes will cause a slight decrease in mean arterial pressure. And this will be detected again by the nucleus tractus solitarius. And what that does is it's going to release more sympathetic nervous system drive. And I'm drawing it on the left side for a reason. And what that's going to do, also disregard the fact that these are purple. This is by accident. Let's just make them black. Yeah. Like I said, it's going to increase your sympathetic drive. And in case you're confused to what sympathetic drive means, just means the amount of norepinephrine being released by those nerves. It's going to increase your sympathetic drive, and that is going to do two things. Again, those very same two things we did, which is in your alpha receptors, it's going to cause vasoconstriction. And in your heart, it's going to increase your heart work, which means increased stroke volume, increased heart rates, which means increased cardiac output. If you're confused as to the alpha beta distribution, just know that alpha beta refers to the epinephrine receptor. So it's they're known as adrenergic receptors, based on adrenaline. And there's two classes, and they're distributed on different structures. But just know the ones acting on the heart, they're alpha, and the ones acting on the ones acting on the vessels are alpha, and the ones acting on the heart are beta. And it does the exact same actions that we talked about and we keep talking about, which are essentially focused on doing three main things: increasing your total peripheral resistance, increasing your cardiac output, and is eventually increasing your mean arterial pressure. That is the whole point of this. On the other hand, we do have our parasympathetic nervous system. This is just decreasing, because if we have a decrease in pressure, we don't want an increase in parasympathetic nervous system for all the reasons we said. Now, kind of looks different from my other drawing, but they both convey the same meaning, I promise. Essentially, like I said, you have your local vasodilation, your metabolites, that cause a very small transient decrease in your mean arterial pressure, which is detected by your nucleus tractus solitarius. And the whole point of that is just to increase your sympathetic nervous system activity, and in the hopes of fixing that. However, in this case, because what's happening here, and I forgot to write that here, because of what's happening here, we're having this vasodilation occur. This vasodilation, it is actually stronger than the total peripheral resistance that we have going on by the sympathetic nervous system. What this means is that even though we have increased sympathetic nervous system drive, total peripheral resistance is going to decrease. And essentially, this is just due to the fact that total peripheral resistance, the amount of metabolites being released by that muscle are so much more than the adrenaline being released by the sympathetic nervous system that the blood vessels, and only the blood vessels to those muscles, they are dilating massively. They are dilating massively, and put into the context of all your blood vessels, the total resistance is decreasing massively. This is a good thing. It's not a bad thing in this case. It's a good thing because you do want that increased uh you do want that increased blood flow because your muscles are working hard. Okay, this is just connecting everything together with the drawing that Dr. Simon has included. Again, they look different, but they convey the same meaning. Essentially, we have our exercise. We have a local response, which is going to cause that dilation that we talked about. It's going to cause active hyperemia. Again, that is just based on the previous lecture. It's going to cause that local vasodilation, which is going to decrease your total peripheral resistance. And that decrease is so much stronger than that increase from the sympathetic nervous system. So the overall effect, the sum, is a decrease in total peripheral resistance, and this is a good thing in this case. You want a decreased total peripheral resistance because you do want that increased blood flow to those vessels. Okay, great job for making this far. If you have any questions, please do not hesitate to ask. It's completely fine. It is a dense topic. However, just review it a couple times. You will find that it is far more easier than you'd imagine. And yeah, let's just begin. So we have two questions here. The first question, a healthy 22-year-old female medical student has an exercise stress test at a local club. An increase in which of the following is most likely to occur in this woman's skeletal muscles during exercise? And you have around 5 choices there. And our second question is a healthy 25-year-old male medical student has an exercise stress test at a local health club. Which of the following physiological changes is most likely to occur in this man's skeletal muscles during exercise? So again, it's very similar. Both questions are very similar, but try to answer them on your own and then put the answer in the chat or just speak up and we'll discuss them. Give me a minute, guys. All right, so does anyone have an answer for us? Anyone to try answering these two questions, or at least one of them? Okay. We have one answer in the chat. Does anyone else have any other answers before we move on? Okay. So one of your colleagues answered E for the first question. And that answer is indeed correct. Essentially, all of these changes are occurring. You do have increased vascular conductance because, again, all those metabolites are increasing. You have increased blood flow because you have the sympathetic nervous system, sympathetic drive is increasing. You have increased carbon dioxide because increased muscle work. You have increased arterial diameter. Essentially, these are all describing the same thing in just a different direction. And they're all just related to each other. So more muscle work means blood vessels are dilated because it's allowing the muscle to take up more blood. Now, our second question, yes, our second question, both of the answers in the chat are correct. It is indeed G. So why is it G? Let's think it through. So this person is exercising, and when he's exercising, he's producing an increased number of metabolites. Essentially, he's producing an increased number of chemicals that are resultant from the breakdown of other chemicals. So if you have ATP, you're using ATP. You're taking one phosphate away, it's becoming ATP. That's essentially what adenosine means. So adenosine is increasing. So right off the bat, we can eliminate half of these choices. Now, because adenosine is increasing, you do have that that reflex, that metabolic theory of vasodilation, and this is going to cause a decrease in arterial resistance. Now, remember that a decrease in resistance means an increase in vascular conductance because more blood is being able to pass through those vessels because they're just simply wider. They were like this, they did this. And purely because of both, just purely because of the metabolic theory, actually. The sympathetic nervous system, its main function here is just to increase the flow of blood around the whole body. And that production of metabolites locally allows that blood to be directed specifically to the exercising muscles and away from non-exercising organs and muscles, such as the digestive system, for example. So when you're running, you have increased sympathetic nervous system drive, and you have increased vasodilation in your running muscles. So the blood is simply just being directed to those muscles that are in use. All right. The next section of our topic today is the Valsalva maneuver. This is my favorite topic, actually. Essentially, the Valsalva maneuver, it's a maneuver that allows to increase thoracic pressure and in a way also abdominal pressure. So it's used in a lot of different diagnoses, and it's used in pregnancy, especially parturition. So in birth, it's used in defecation and of course in weightlifting. So when someone's like in a weightlifting competition, like that is a Valsalva maneuver. Essentially, you breathe in, you hold it for 10 seconds, and you forcefully exhale. Now the thing is with a Valsalva maneuver is that it causes a very unique trace in the aortic pressure graph and the heart rate graph. And you really need to be able to understand the maneuver in depth to understand why each change is occurring. So, and one nice little aspect of the Valsalva maneuver is that it's used to evaluate your baroreceptor reflex, and we'll see how that happens. So, the first phase of the Valsalva maneuver is your deep inspiration and your forced exhalation. Okay, so just your forced exhalation with your mouth closed. What this does is it's gonna compress your aorta. Remember, your thorax is a closed cavity. Once you're trying to exhale, so your muscles, your external and external and internal intercostal muscles, they're pushing down so hard now. They're trying to exhale that, they're trying to push that breath out, even though there's nowhere for it to go. So this is where what's going to happen. It's going to compress all the structures, including the heart, the aorta, the vena cava. It's going to compress all of them. That compression of the aorta is going to raise that blood pressure. It's going to raise it not very high. It's going to raise it by a substantial amount. This is detected by our friends, the baroreceptors, and that's going to cause a decrease in heart rate. Because again, an increase in baroreceptor firing is going to cause a decrease in heart rate. A decrease in baroreceptor firing, like we said, is going to cause an increase in heart rate. So the rise in aorta blood pressure is detected by baroreceptors who decreases. And that's very important. So this is all phase one. Okay. The second phase, now, because both your aorta is constricted, and remember, this is going on for 10 seconds, not for 2 seconds, not for 3 seconds. As in, this is stopping the flow of blood. It is a very strong reflex. Because both your aorta and your vena cava are constricted, this is compromising the flow of blood around your body. This means that the blood is not circulating as it should be. Because it's circulating everywhere else, but your thorax, it's like stopping. It's stopping here, it's stopping here, it's stopping in your inferior vena cava. Now, this eventually means that the blood pressure is going to just decrease. Even though it's constricting everything, blood pressure is decreasing because the heart is it's like, I'm not pumping anything. Where is the blood? So what this does is that this actually counteracts that decrease in heart rate that we saw. It's gonna be detected by, again, the baroreceptors who are gonna start firing, so they can increase the heart rate. And this doesn't really change the blood pressure because even though the heart is pumping more now, it's still not receiving enough preload to actually make a difference. And you can kind of see here. So lack of venous return decreases pressure, but it increases the heart rate. Now, phase three is when the patient exhales. So they finally open their mouth. What that does is it causes a very small dip. That dip is just caused by the aorta going from like this to this. So that decreases blood pressure quite quickly, which does a transient increase in the baroreceptors. And this causes our first peak. So this is the peak in heart rates, okay? That peak in heart rate is simply caused by the aorta reflexively expanding massively and all the blood just bouncing off its walls, essentially. Now because the heart rate is peaking, again, sorry, ignore that. Essentially, what happens first is the aorta expands and the heart rate peaks. In our fourth and final phase, because we've just seen heart rate, peak, in addition to the fact that everything is now unconstricted, so the vena cava was constricted, the aorta was constricted, and everything is open. The heart is seeing more blood come in. So all that blood that was just waiting to pass through the vena cava is just rushing back in now. The heart is pushing out so much blood. What happens is you have this massive increase in aortic pressure. Could you please repeat the previous slide? Sure. So going back to phase 3, and I'll go back to phase 4 for you later. Essentially, the patient is opening their mouth. What this does is that it releases all the pressure that was in their thorax. That release in pressure is going to unconstrict the aorta and the vena cava. What this means is that the pressure in your aorta is going to dip. It's going to dip because that aorta is just expanded now. It was compressed, now it's uncompressed. So that means there's more volume for the blood, for the amount of blood inside the aorta is going to decrease pressure. Okay? What that does is it's going to cause your baroreceptors to detect this. And what they're going to do is essentially they're just going to increase heart rate. This is going to cause a peak in the heart rate. It's going to cause the highest heart rate seen in the Valsalva maneuver. It's in phase 3 because the patient just exhaled and the aorta is expanded. So in phase 4, this is essentially like the consequences of your actions if you were the aorta or if you were the person. So because we just, of course, yeah. Because we just unconstricted that aorta and the vena cava, because remember, these are all in the thorax, they're all being constricted. Because we just unconstricted them, all that blood that was pooling and just waiting to move through behind this obstruction is freely flowing back and it's freely flowing through. So we have an increase in venous return. This is a massive increase and it's going to cause a massive increase in aortic blood pressure. This is going to cause our blood pressure peak of the Valsalva maneuver. Okay, this is actually caused by venous return, whereas the peak we saw in phase 1 was caused by the Valsalva maneuver. So this is due to pressure outside the aorta. This is due to pressure inside the aorta. And it's easy way to remember it is that this one almost looks like it's being pushed from this side and that side, whereas this one, it's just massively dilated. So just imagine more blood. Okay. Now the consequences of this, why does phase 3 cause an increase in heart rate if the aorta is expanding? So decreasing, why does phase 3 cause an increase in heart rate if the aorta is expanding, so decrease receptor firing? Well, the thing is, in phase 3, the aorta is expanding, but again, we didn't have venous return. So the aorta is expanding for a very small amount of blood. Because remember, that blood was just constricted. So you have your vena cava, your inferior vena cava, and your superior vena cava, those are constricted. So no blood is going through. But as soon as you let go, everything just dilates like that. But it's not enough time for the blood to actually come through. We see the blood coming through in phase 4. So even though the aorta dilates, the actual blood flowing through the aorta is very little. So our baroreceptors detect this immediately and they increase heart rate. I hope that makes sense. So in phase 4, we see of course, in phase 4, again, we see this massive rise in aortic blood pressure because all the blood is now flowing back into the heart. It's flowing through the aorta. Easy way to remember it is if you have a big fat red line, just know it's because of the blood. Why is the heart rate decreasing in phase 4? Yes, we are reaching that. So essentially, because our aorta is so massively full of blood and the heart rate's extremely high, because all that blood that was pent up has just started flowing now, the baroreceptors decrease. The baroreceptors detect this and they reflexively, massively decrease the heart rate. Can someone tell me how exactly the nucleus tractus solitarius is decreasing this heart rate? So what is happening in the integration center that is causing a decrease in chronotropic activity? So a decrease in sympathetic activity. Yes, someone said with GABA, but can someone tell me how exactly with GABA? Because GABA can actually do opposite things depending on the different paths in the nucleus tractus solitarius. Yes, exactly. So in one way of saying it is it does inhibit vasomotor activity because you have increased, let's go back to that slide. I know we want to move over, but yeah, so let's go here. So because we actually have, in this case, a increase in the signals coming through here, what these are going to do is they're going to go to the nucleus tractus alterius, and it's going to increase the negative signal coming out from the central ventrolateral, called the caudal ventrolateral medulla, and that is going to inhibit the vasomotor center. But at the same time, this increased signal is just going to go to the cardioinhibitory center and cause increased parasympathetic drive, which again is going to decrease the heart rate. So just constantly keep going back over to our same drawing, and inshallah, your drawing, and it's going to really help you comprehend all the changes. So like we said, phase 4 caused a trough, caused like a valley in the heart rate. The lowest heart rate you're going to see is in phase 4. Now, the thing is, this is used to detect the baroreceptor reflex viability. Essentially, if your baroreceptor reflex is functioning, you should see bradycardia here. If it's not, you don't see bradycardia. This person has a dysfunctional baroreceptor reflex. Additionally, because we have an extremely high aortic pressure here, this means our heart has to work extremely hard to pump blood. And this could kill someone who has a faulty heart, who has heart failure, essentially. Exactly. So for patients with heart problems, phase 1 and 4 are dangerous because the aortic pressure is extremely high, and someone with dysfunctional heart is essentially going to have to work so much harder to pump blood through these vessels. Additionally, the the Valsalva maneuver exacerbates hemorrhoids. Now, remember how I said that this increased thoracic pressure in phase 1 specifically? It's compressing all the contents of the thorax. And the main structure going through the diaphragm is the inferior vena cava, alongside the aorta, of course. Um, if that's constricted, then all the blood coming from below the inferior vena cava is pooling up essentially. And especially, where's it going to pool? In these capacitance vessels. It's going to pool in your lower extremity veins, and it's also going to pool in your rectal veins. So it could exacerbate hemorrhoids. Now, let's apply what we learned. So why is the Valsalva maneuver contraindicated, which means not advised to be done, in a myocardial infarction patient? So can someone answer this for me? Okay, we have one answer. Okay, we have two answers. So your colleagues are saying C, and that is entirely correct. Essentially, following the release of the Valsalva maneuver and following the what's it called, the onset of a Valsalva maneuver, we have extremely high aortic pressures, as you can see here and here. This means the heart has to work really hard, and then someone with a really bad heart, this could kill them. Now, our second question is, what caused the second peak in aortic blood pressure? I gave you a very handy way of remembering it. Can someone answer this? Okay. Yes, finally, we have two opposing answers. Someone is saying C, someone is saying D. Now, for each person, can you all just give me a one sentence explanation why? So someone is saying that increased aortic constriction leads to increased pressure in phase 4. And the second person says released flow of capacitance vessels and restoration of blood flow. I'm going to give you guys both just like 30 seconds just to type me up an explanation. But essentially, if I may just spoil the fun, um, in phase 4, what we're seeing, like I said, is we are seeing the restoration of blood flow because we released the Valsalva maneuver in phase 3. Um, we released the Valsalva maneuver in phase 3. Now, what that does is that is going to transiently increase, it's going to dilate the aorta because, again, there's no more pressure compressing the aorta. But more importantly, it's going to dilate the vena cava. The vena cavae that are dilated can now, the blood that was pent up, the blood that was essentially stopped from flowing, can now flow back into the heart. Um, and that increased flow, that increased venous return back into the heart is going to cause a massive increase in aortic blood flow and it cause massive increase in blood pressure. So the answer is D, simply because increased aortic constriction is what happened in phase 1 because it was being constricted. The opposite is now happening. The aorta is not constricted. The aorta is actually full of blood. So this is why it's D. Remember, the first increase in aortic blood pressure is sort of skinny. It's sort of compressed. Like, look how pinched it looks here. This is because of that increased thoracic pressure. Now look at how unpinched it looks here. Look how wide and full of blood it is here. And this is because of the blood flow, the increased venous return. So yes, someone said C is the first peak. That is extremely correct. Essentially, C is just describing peak 1, whereas D describes peak 2. I encourage you guys to really just look over this. It's a great way of understanding the Valsalva maneuver, and once you draw it out, you'll never get it wrong in the exam. Trust me. Okay. Our next section is regarding shock. And it's a pretty short section, but essentially what shock is, and you don't need to know much about shock in first year. You're going to have an entire lecture on just shock in second year, so don't worry about that. But essentially, it's your heart or actually your entire cardiovascular system collapsing. It's known as cardiovascular collapse. This means that your organs are not seeing enough blood. And this is going to be presented in a lot of different ways. But there are multiple forms of shock. So, and we're going to go over them. But shock, it's going to have one of 3 failures. Either your heart is failing, either you don't have enough blood, or the vessels are failing. And the 5 types of shock, they all have one of these occurring. So cardiogenic shock is cardiac failure. Blood volume based failure is hypovolemic shock. Vascular tone issues, this is seen in septic, and neurogenic, and anaphylactic. You don't need to know anything about septic, neurogenic, or anaphylactic shock at this stage, other than the fact they exist and they're forms of shock. You're really going to go over much more in depth into every single type of shock in year 2. But what you do need to know is hypovolemic shock and cardiogenic shock. Hypovolemic shock, it's essentially loss of blood volume, and it's occurs in vomiting, in hemorrhages, in dehydration, and in burns. And cardiogenic shock, it just means that your heart as a pump is failing. And it could be right, left failure, it could be systolic, diastolic failure. We'll get into that in just a bit. So shock has 3 main stages, and you need to know the stages of shock. This is important. This does come up on exam sometimes. And the first stage of shock is non-progressive or compensated shock. Essentially, this is your cardiovascular system failing, like we said, that is what shock is, but it is essentially compensated, as in all the mechanisms that ensure nothing goes wrong are active. Your blood pressure slightly, it doesn't even change almost. And this is seen when you lose 10% to 20% of your blood volume. So this is why when you donate blood, you don't die, essentially. Um, your heart rate's going to increase. Your total peripheral resistance is going to increase. So it means less compliance. And your renin angiotensin aldosterone system is going to increase. Now, you don't need to know much about RAS right now, but RAS, it's a kidney-based mechanism of maintaining blood pressure. So compensated means your body deals with it. It's okay. Uncompensated, essentially when you start to see signs of something going wrong. So this is going to be acidosis. This is going to be skin mottling. What skin mottling is essentially like you have patches of skin that are purple. So the color is very odd of the skin. You're going to see um, different presentations of skin mottling, but essentially if you see it mentioned, just imagine that all the capillaries in your body are just constricting and they're essentially stopping the blood flow to your skin because your body needs all that blood in the areas where it doesn't need it, which are your brain, your heart, your lungs, all those. You'll see something called DIC. You don't need to know anything about DIC right now, but this is just for your own knowledge. And you also see mental confusion. Mental confusion simply is because we're not seeing enough blood to our organs, and the person's just confused. And not a coma. Coma is more irreversible shock, but they're beginning to show those bad signs. And finally, irreversible. The irreversible stage of shock, it is the worst stage of shock. It happens when you have blood loss over 20%. Um, Essentially, it's organ failure. So they'll talk about a decrease in urine output. They'll talk about increased carbon dioxide concentration in the expired air, decreased inspired oxygen. So they'll talk about like signs of the organs going wrong. So something is going wrong. And this is because the organs are dying due to ischemia. So so I actually added this slide here because on an MCQ, I don't remember specifically if we were asked shock, but I do remember that when I was studying shock and doing the practice questions, it was hard to kind of discern if it was shock or not. So you have to look out for keywords. And I gave you a very nice list of keywords here that are seen in every single shock-based questions. So pale, cool, clammy skin, confusion, elevated respiratory rate, heart rate, mottling, low blood pressure. So, and this is an example where you kind of see all of them. So let's look at some shock-based practice questions. Could you please repeat the second stage of shock? Sure. So uncompensated shock, it's when we begin to see signs of failure. We begin to see signs of organ damage. So all our mechanisms, they were at like full work. They're failing because it's just getting so bad. So you start to see some signs of it. The patient isn't dying, but they begin to be very confused. Their pH is very low. Their skin is mottled. That means areas of skin are hypoperfused. It's going to be purple. And this is because all those capillaries are clamped tight shut, but this isn't enough. And you don't need to know the mechanism behind any of these right now, but just know that they kind of point to a stage of shock that is not perfect, but it's not dead. But it's not death. And you see death, coma, organ damage in the third stage of shock. So just know if you see any of these cardinal signs of shock, you kind of quickly associate it as uncompensated or progressive shock because it's progressing to something worse. Oh, oh no. Sorry. You didn't say anything. Okay. So our question is: a 16-year-old boy is involved in a knife fight and is transferred to the emergency department. A severed artery in his forearm is bleeding profusely but is not controlled. His blood pressure is 100/70. Which of the following cardiovascular parameters are lower during compensation for hemorrhage than before the hemorrhage? Um, so this just means one of these is less now than it was before the hemorrhage. Can someone answer and tell me why? Again, as you can see, all of this needs really good knowledge of the nucleus tractus solitarius and the baroreceptor reflex, because it does help you answer all of these questions. Someone says a question mark. Yes, it is A, but we need to be more confident. Essentially, it's talking about something that is lower now than before the stab wound. So what is lower now than before the stab wound? Is it arterial resistance? Well, no. Arterial resistance, if anything, would be increased because that sympathetic nervous system is trying to clamp down on the blood vessels to maintain blood pressure. And as you can see, he has very low blood pressure. Capillary fluid reabsorption, you have another. This is a type of shock, yes. So because again, look, okay, so this is a type of this is a case regarding hypovolemic shock. So the main tell for hypovolemic shock is, like I said, if you have bleeding, vomiting, diarrhea, or dehydration, essentially it's loss of plasma. So it says he was bleeding profusely and he was involved in a knife fight. This is a telltale sign of hypovolemic shock, and we can tell that something is wrong because it has very low blood pressure. So A is the answer. And whoever answered A, you are correct. Because these baroreceptors, they were firing higher before the shock than they are now. Because remember, baroreceptors, they just fire off always. They're constantly on. And it is the decrease in baroreceptors that calls in extrasympathetic activity. Now, it's not capillary fluid reabsorption, because would your capillaries really be reabsorbing fluid if they're clamped down shut? They wouldn't. Is it total peripheral resistance? If anything, no. Total peripheral resistance is massively increased following a traumatic event such as this one. And ventricular contractility, of course, is increased now than it was before. Okay, so that is it for shock. Does anyone have any questions about that shocking segment? Generally increasing resistance increases venous return and blood pressure. Yes. Usually in most cases, when you increase the total peripheral resistance, what that does is it kind of forces the blood to move through the system. Even though your veins don't contract, the artery is contracting here. So you have your artery, vascular bed, and then your postcapillary venule. It just moves the blood along. Again, as you've seen, you can't really rely on just this occurring to maintain blood pressure. You do need to actually move. But it is one of those mechanisms. So now let's talk about heart failure. It's a pretty short and sweet segment. And yeah, but it comes on SAQs and OSFI so much. I remember our SAQ had a heart failure question and everyone was very sad about it. So going through appeals as a BLC just for this question was incredibly disturbing. So yeah, what is cardiogenic shock? So cardiogenic shock, essentially it's a synonym for heart failure because cardiogenic shock is referring to your heart being incapable of pumping blood. So this is essentially based on heart failure. So either the heart can't pump blood or it can't fill adequately. So it can be right, left, or could be diastolic, systolic. If it's right-sided versus left side, that's kind of just based on where the fault is, and it's going to cause presentations right behind the points of failure. And if it's diastolic, systolic, that just refers to the action occurring. So is it a failure in filling or is it a failure in pumping? So a very nice way of measuring the status and the function of the heart is via something called the cardiac index. You really should memorize it because I feel like it does come up on exams. Essentially, this is the cardiac output, which is in liters per minute. And I really, side note, I encourage you guys to really study the hemodynamics lecture, specifically the equations for cardiac output. This came up on our MCQ, actually. We had to calculate stuff on our MCQ. And you really do need to be aware of this. So it is cardiac output over total body surface area. This is your cardiac index. And if it's ever below 1.8, you need to really, really pay attention because that means the patient is cardiogenic shock. They have heart failure. So let's talk about the difference between right and oh my God, I just realized I put right. Oops, this can't be right. Can you just guys give me a second while I fix this? Yeah, but before I go, someone said, can you repeat the number for cardiac index? Yes. So if it's below 18, then that's shock. Think of it as if someone's a minor, if someone's a minor, it is an issue. So you have to be above 18, to like drive, to do anything. You need to be above 18. Cardiac index also has to be above 1.8. BSA stands for body surface area. This is calculated essentially through a method called the rule of nine. You don't know this. They'll give you a number if they want you to calculate this. But just be aware of what it means. This means your entire body on a 2D surface. That's the only way I can explain it. And then cardiac output, you all know what cardiac output is. Can everyone just give me 2 minutes while I fix these slides? And yeah. Okay. Thank you all just for waiting that small pause. So yeah, let's discuss the heart failure, classified whether it's left or right. Essentially, left-sided heart failure, it's based on the left ventricle because that really is just the main functional um, structure in the left side of the heart. Essentially, this means the heart is not pumping blood towards the entire body. So it's failing in that one stage. So your left ventricle, it's failing, okay? Because it's failing in one way or another, it could be due to pumping blood, due to receiving blood, the blood is going to pool right behind that point of failure. And I have a very nice like linear diagram that can help you understand this. It's pooling right behind that point of failure. Now, you have to know the flow of blood throughout the heart to really understand this. But where's the blood coming from before the left ventricle? Can someone tell me? Just very, very rudimentary question. Where is the blood coming from before the left ventricle? The lungs. Yes, thank you. The blood is coming from the pulmonary veins. So this means you're gonna get pulmonary edema because that blood, it's just it can't go through and reach that left ventricle. Or it is, but it's just not a very compliant left ventricle. What's gonna happen is you're gonna have decreased cardiac output because again, we're just not pumping much blood now. You're gonna have increased pulmonary volume, so you have more blood being shoved into those pulmonary veins and arteries, and increased pulmonary capillary hydrostatic pressure. Now, this is really important because what this might cause is it might cause pulmonary edema, which is horrible, and that might lead to pneumonia. Now, pulmonary edema leads to pneumonia, and pulmonary edema also interferes with your gas exchange. So this could cause respiratory failure, even though your heart is failing. So it's really important to look out for this. And obviously, because our left ventricle is now failing, our left atria is going to be enlarged. What this is going to cause, if you see atrial enlargement anywhere, just think of the P wave. The P wave is going to change if you have left or right atrial enlargement. The P wave is going to change. And unfortunately, I couldn't find a ECG of that, but I do advise you all to find ECG of the changes that happen in atria based on heart failure. It's very nice, it's very clear. And you're also going to have right heart failure if you have left heart failure. So the thing is with left heart failure, because the left ventricle is after the right ventricle in the cardiac cycle or in the flow of blood, having your left ventricle fail is going to cause the blood to pool in your pulmonary capillaries and your pulmonary veins and your pulmonary arteries. What's that going to happen? That's going to increase the pressure needed by the right side of the heart to actually pump blood, which means your right side of the heart needs to work harder to pump that blood. Okay, can you please repeat the ECG part? Sure. So essentially, because you have an increase or because you have non-compliant ventricles in right or left-sided heart failure, so that means the blood is pooling. Because the blood is pooling in the ventricle, or it's going to pool behind the point of failure. So really, if the ventricle is closed off, it's going to pool in the atria. The atria is going to become dilated. It's going to become enlarged. What that does is that messes up all those conduction pathways within the atria. So if the electricity would go like this, it's now going like this. That is going to be seen on the ECG. When you see it on the ECG, it's going to cause splitting of the ECG because the electrical activity is not now linear. So you're going to pick that up on an ECG, and it's going to be very indicative of right or left side heart failure. Now, a nice segue into right side heart failure is how left side heart failure can cause right side heart failure. So because you have increased pulmonary pressure, your right side of the heart needs to work harder to overcome it. This could cause failure of the heart. Now, when the right side of the heart fails, the blood is going to back up into where? The right atrium. When the right atrium is backed up, what's going to happen is the blood's going to back up into your inferior vena cava and in your superior vena cava, mostly your the inferior vena cava. When the blood backs up into your right atria, it's going to back up into your jugular veins, so that you're going to have increased JVP. Yes, jugular veins are relevant. Please study that one part of hemodynamics. And most importantly, it's going to cause peripheral edema. So why is peripheral edema occurring? Essentially, it's the blood is all backed up. The blood is not flowing through as it should. Because the blood is not flowing through as it should, it's just going to back up throughout the entire circulatory system, and it's going to increase hydrostatic pressure. And it's going to move out of those capillaries. And very clearly, you will see, I think I have it here on this one. You will see the blood is backing up into the liver. So it's going to back up into the jugular veins or the liver. And this is going to be very clear. They're going to tell you a patient comes in with hepatosplenomegaly, a patient comes in with like dilated jugular veins. They're going to have increased AST, ALT, bilirubin. Don't worry about what those mean right now. Just know that the liver and the jugular veins are affected right side heart failure. So that's it for right side heart failure. Essentially, it means that your heart is not receiving blood anymore because it's not functioning. So the blood is backing up, either backs up or backs up down. But for left side heart failure, when the blood backs up into the lungs. Now, this can cause right side heart failure. So it's left, so look left before you look right. But it's very important to know what is going to happen after each. So a very handy way of remembering it is, like I said, if you're driving, if any of you drive, you look left before you look right. And essentially, left side heart failure is going to come before right side heart failure in a severely injured person. Okay, now that's it for the left-right difference. Let's look at systolic versus diastolic. So systolic, diastolic, it's much more clear than left or right side heart failure. Essentially means you're either failing to accept blood or you're failing to send blood. Now, a cause of systolic dysfunction or systolic heart failure, this could be due to an MI. So an MI is a myocardial infarction. This means that you had an occlusion in a cardiac artery. So for example, let's say your left anterior descending or your PIA, one of those is occluded and the heart cells, the cardiomyocytes have died. So your heart can't contract like it used to be. It could be due to extremely high afterload, so due to aortic stenosis, and it could be just hypertension. Essentially, your blood, it's failing in its one job to send, your heart is failing in its one job to push blood out because for a number of reasons, either it's simply damaged or the afterload or the work, it's too much for it. Now, the second type of dysfunction is diastolic. Now, this is due to the heart not being able to relax or fill the ventricle. This is due to a non-compliant heart. I know you guys hate that word, but essentially this could be left or right-sided. And most likely this is, again, reduced ventricular compliance caused by concentric hypertrophy. So this is actually also caused by hypertension. So hypertension causes both, I know. Because your heart is pumping, it's basically hypertrophy, which means thickening. It's thickened, and because it's thickened, it can't hold as much blood as it used to be. So it's not receiving as much blood as it should be. This also could be due to reduced preload. So, you know, Starling's law. Essentially, essentially what happens that if you don't have enough blood coming in, it's not going to be able to fill as much as it should be because the more blood you have, the more it can fill. So it's like a positive loop again. So any number of issues can cause either systolic or diastolic, but really all you need to know is just, is the blood, is the end diastolic volume okay? Is the end systolic volume okay? If one of those are changing, you can assume it's systolic or diastolic based on what exactly, what parameter is being changed. So I included this, and I have a question. How is systolic caused by hypertrophy? Okay, so systolic dysfunction isn't really caused by hypertrophy. That's more so diastolic. Systolic, I know I said systemic hypertension. What that means, that means afterload is extremely high. So because the afterload in systemic hypertension is so high, the heart needs to work so much harder to overcome the aortic valve pressure to open the valve. So this can cause failure of the heart because it's working so hard, it can actually damage itself. And the damage is most likely caused by ischemia. Remember when I said that exercise causes angiogenesis of the heart? In someone who is sedentary and they have hypertension, their heart does not have that angiogenesis. Their heart does not have extra blood vessels to help it deal with the extra mass on the heart. It doesn't, and because they're working so hard, their heart just dies because of lack of oxygen. Um, so yeah, these are the two timelines I made for you regarding left versus right-sided heart failure. Honestly, I think it's invaluable when you structure it like a way because let's say you either have a stenosed aorta or a myocardial infarction. So this means that your heart, it's the systolic function of your heart, it's damaged, or the left side of your heart is damaged. This is just left versus right. Systolic versus diastolic doesn't really come in exams, but left versus right is super important. So remember, like I said, everything before that point of failure is affected. So if the point of failure was your left ventricle, all the symptoms are going to be seen behind it. So this means you're going to see left atrial enlargement. This means you're going to see an S3 sound. Um, what an S3 sound is, S3 sound means just means not compliant. It means the ventricular wall, it's very thick, it's not welcoming, it doesn't expand as it should be. So you're going to see increased left ventricular function, which really means decreased stroke volume. So decreased left ventricle, decreased stroke volume. Again, the one thing that it does. Can right-hearted failure cause left heart failure? No, cannot. Because really, when you think about it, if the right side is failing, the left side is actually dealing with less work because less blood is flowing through the heart, the cardiovascular system, so less pressure. It's like taking a vacation, essentially. But if it was the other way, no. Again, look left before you look right because that's the way it just the point of failure develops. So yeah, I encourage you guys just to take a look at both these timelines. It's really helpful. I kind of just broke down all like the sequelae you'll see, essentially all like the side effects you will see due to left or right side heart failure. So for example, left side heart failure, you're gonna get pulmonary edema. Why? Because the point of failure is in your left ventricle. So your left atrium is gonna be affected. Then your fluid's gonna back up to your lungs. Then you're gonna get pulmonary edema, and then you're gonna dyspnea, then you get pneumonia, then you're gonna respiratory failure. So just kind of think of the sequence of events. Important thing to note is that if your atria are enlarged, you can actually get atrial fibrillation and arrhythmias because again, those conduction pathways in the atria. So you pick that up on the ECG. The P wave is different, but that essentially means that the electricity in your heart is not flowing like it should be, and that could be dangerous potentially. And honestly, that's kind of it. You'll see some of the symptoms are very similar, so you get S3 sounds in sides of both sides of heart failure. And but the edema is different. In right-sided heart failure, the edema is really systemic, so it's peripheral edema. It does pit, because pitting edema is usually seen with issues due to cardiovascular and lymphatic the system. Whereas non-pitting is usually more seen due to like hypothyroidism and such. So yeah, these are the two timelines. You don't need to understand anything really beyond just what is written here. just know that you're going to get a case in your SAQ most likely with one of these things on it, and you're going to be asked what also happens. So I encourage you all to I encourage you all to just thoroughly look this over, kind of understand why, in addition to what. And we are now at our final case break, so let's look at some questions. So, which of the following conditions is associated with an increase in mean systemic filling pressure? So this kind of sounds hard, but what is mean systemic filling pressure? Mean systemic filling pressure just means your right atrial pressure. So this means that your right atrium, so your venous return is increased. So your right atrium has a lot more pressure needed to actually have the blood flow to it. So can someone answer this? Okay, we have one answer. We have two answers. So someone says C and someone says B. Let's discuss it. So in C, in congestive heart failure is another term used to describe systolic heart failure. Essentially means the heart is not pumping as much as it can. So you're having, let's say, a buildup of fluid in an area. Now that buildup of fluid, of course, will cause an increase in pressure. Now it's not the nice kind where you have increased venous return. It's actually the bad kind where you are having less venous return, but increased pressure. And this occurs because that fluid shouldn't be there normally. So this will cause an increased MSFP. And oh my God, I forgot to highlight the correct answers. But yes, it is indeed B. Sympathetic inhibition wouldn't cause a increased right atrial filling pressure, simply because that would actually decrease it. Because you're having less total peripheral resistance, which means less blood is flowing through the circuit. Okay. So the second question is, what organ could potentially be damaged in right-sided heart failure? Can someone answer this based on the timeline that we saw? Okay. Okay, can we get one more answer? Okay, so we have again two answers. Our first answer is E. So unfortunately, the answer is wrong because remember, in right-sided heart failure, you have the right ventricle. Everything behind the right ventricle is failing. So that means everything behind the right ventricle is dilating, full of blood. So in a way, this question could potentially accept two answers. Yes, in a way, yes, it could mean that the brain is seeing less blood, but really in this case, the congestion of blood behind the right ventricle is what caused the damage. And that damage is typically seen as a very, very congested liver. It's going to cause something called nutmeg liver. And this will almost kill the liver essentially because the liver can't do what it was supposed to do, which is deal with metabolism instead of dealing with a bunch of extra blood. So yes, the answer for this one is indeed D, which is the liver. But didn't we say that jugular vein pressure increases? Now, yes, jugular vein pressure does increase, but that doesn't really cause a issue in the brain because the jugular veins, in this case, they can be distributed also to your subclavian veins. So your right extremities are like essentially reservoirs, but you don't have that in your abdomen because what comes after your inferior vena cava is just your liver. So the closest thing essentially is going to get affected, which is your liver. And that's kind of the reason why we see that pattern. So yes, I apologize for not highlighting the correct answer. Inshallah. Yeah, can we go through the timeline? Yeah, of course. So I'm gonna send this slideshow to everyone, inshallah. But essentially, as you can see in right-hearted failure, this is what the question was about. We have our points of failure here, and it's just gonna back up everywhere behind that. And it's gonna back up one into your jugular veins, yes, but also into your liver. Just kind of think of it, what's the organ closest? And the liver is indeed the closest organ by virtue of the circuit. So you're going to see hepatomegaly, nutmeg liver, and increased liver enzymes, plus bilirubin. So yes, I do encourage you guys to just digest these two timelines in whatever way you can, make Anki cards, try drawing them out, whatever way is really going to help you. It's clear now. Perfect. So that is really it for me today. Thank you guys so much for being with me. I really enjoyed this talk. Inshallah, you guys benefited from it as well. If anyone has any questions regarding this topic, really, or really any other topic, please don't hesitate to either text me or email me. I prefer the texting, of course. And yeah, please fill out this form. I do have to tell you guys to do that. So yeah, I really do hope that you guys benefited from this talk. If anything was not clear, just tell me, and inshallah, you will do great on your CVP exam.